John Grant is a professor of psychiatry and behavioral neuroscience at the University of Chicago, where he directs a clinic and research lab on addictive, compulsive, and impulsive disorders. Dr. Grant is the author of over 400 peer-reviewed scientific articles. Yes, I said 400, 15 books, and is the editor-in-chief of the Journal of Gambling Studies. Dr. Grant, we've got you on one of our videos on that 4-day core gambling course that I see you speak on all the time, but I just told you that I saw you speak a couple of years ago in North Carolina. Man, you're a great dynamic speaker. We appreciate everything you've done and that you do in this field. Without further ado, I'm going to go into darkness now, and it's all yours, sir.
Thank you very much.
All right.
Well, I'm speaking today about evidence-based treatments for problem gambling. I should say, at the beginning that we do a lot of treatments in the field of gambling and related problems of other addictions that are not necessarily evidence-based. It doesn't mean that they're not valid and that they're not useful. As clinicians, I think we can probably all speak to doing an eclectic kind of mix. However, when we try to evaluate what treatments have evidence, we can only really base that on what's been published, what type of treatment trials are done. So I just want to put that out as a footnote that I'm going to be talking about those. And it doesn't mean that whatever people are doing isn't good and is wrong or anything, but these are what the evidence would suggest would be the treatments of choice. And I'll even be talking about, as we all know, even when we do the best treatments, sometimes unfortunately our outcomes are not all that good. And I'll be talking about some of the complexity of that. For those of you who don't sort of use some of these treatments, I would suggest maybe thinking about maybe incorporating even elements of some of these into the types of psychosocial interventions that people are doing now. It may be a useful augmentation to what people are doing, to help outcomes improve. My disclosure information, I do have some research support from NIAAA, Alcoholism, a branch of NIH, the Wellcome Trust in the UK, a research grant from a pharmaceutical company, which is irrelevant to this and irrelevant to gambling research. And then I'll talk about some off-label use of medications, because I'm going to be talking about psychotherapy interventions as well as some medication interventions. The learning objectives for this talk, we're going to talk about the evidence that supports all of the interventions that I'll be talking about. Also, what factors may predict who responds better to one than another. And then we'll talk about some difficult cases and how a much more holistic approach needs to be used, even if one is using these evidence-based treatments. But I think we might consider these evidence-based approaches to be at least a core component of the larger holistic approach. I love this slide. I always use this slide, God knows, from the early 60s. And I think it's important from an evidence-based approach, because this is where what we know in the gambling field is not always what we live as clinicians, particularly. This slide shows two very important things. One is that we see a lot of comorbidity. We still see alcohol as a major problem in people who gamble, which needs to be addressed. But also to the right on the screen with just the little hands, we see nicotine dependence. And that's still the #1 co-occurring problem in the treatment of gambling addiction. And so it's very important to address the nicotine. I know that sometimes we may sort of give it short shrift because it doesn't have the immediate financial and social implications, although we're all aware of the huge health implications. But there is some evidence, again, showing that continued nicotine dependence is a predictor of who will relapse after successful psychotherapy for gambling addiction. And so it tends to keep, maybe it's a cued pair response, right? I mean, that I gamble and then smoke, I smoke and then I go gamble, etc. And so, or it could be that it's keeping the neurocircuitry of reward sort of whetting the appetite, but we do find that addressing it at the same time as the gambling becomes terribly important. The other piece of this slide that I do think is also crucial is that it shows women, and this is from a women's magazine, which is why it shows it from the early 1960s. But even though one can sort of say epidemiologically in the big picture, that the majority of people who have a problem gambling are male. It's about 70-30, maybe maybe 65-35. Overwhelmingly, the people who come in for treatment are women. And so I footnote that because even some of our evidence-based approaches, if you read through them, you want to actually be able to critically see, did they have enough women in the studies, right, to actually suggest that this type of psychotherapy is useful in women as well as men? There are some nuanced differences between men and women, and one of those being that women do tend to progress to their gambling problem much faster. So they may start with recreational gambling and then in a very short period of time have a full-blown gambling disorder, whereas men tend to have it more elongated over a period of many years. What that means is, from an intervention standpoint as well, that we probably want to have women get some, even brief interventions at the first sign of having a problem, and not necessarily have to have all of the negative repercussions of full gambling addiction before we offer some interventions for them. I highlight that currently these are still our criteria for gambling disorder according to the DSM-5. And what this means is, you can see you need 4 of these, but different people may have different symptoms. So some people have a withdrawal from gambling, other people don't. Some people lie due to their gambling, other people, strangely enough, don't. The illegal acts is taken out, but I think it's very important to still screen for. What we know is that people who have committed illegal acts due to their gambling, although it's not essential to diagnose it any longer, because by the time people have committed illegal acts, they have enough other symptoms, essentially. But what it has also suggested from a treatment intervention is that they tend to probably need longer treatments and more intensive treatments. So perhaps instead of 4 months of weekly therapy, somebody may need 6 to 12 months if they have had illegal behaviors contributing or due to their gambling, or contributing to their gambling. And so that becomes important. But I'm also highlighting that you can have different symptoms, and what essentially the take-home message means, and the reason that we don't have one perfect treatment for gambling in any, according to any of the studies, is that it's probably fairly heterogeneous, meaning, you take 10 people with a gambling problem, they may have distinct symptoms. Some are preoccupied, others aren't. Some have withdrawal, others don't. Some escape gamble, others don't. They actually like the rewarding, fast-paced effects of gambling, etc. And all of that means that you may have a couple different symptoms, symptom dimensions. You may have different causes, if you will, reinforcing triggers, etc. And we need to be mindful of that one size does not fit all. That even though we try to do that somewhat in group therapy, using a type of therapy, we have to recognize that there are some people in the group who may actually respond well to it and others who don't. And those people who don't may need a qualitatively different type of intervention. And what we're trying to do, at least in the gambling research world, is really to understand when somebody comes in, when Bill Smith comes in, is to be able to do an assessment and find out what treatment is best for Bill Smith. Not which one, is my favorite, or the one that, helped me, or that I use all the time because, right? We want to be able to see qualities of Bill Smith that make our focus on what he gets as treatment the most successful approach. And I'll tell you, we're not absolutely at that point yet. But again, some of the core qualities of addiction which apply to gambling, it's this compulsive engagement in it. We all know that. A loss of control, a craving to do it, a pleasurable quality, about the gambling, right? People start it because it gives them some type of reward. Either it allows them to escape from stress, from depression, or it gives them a thrill. It gives them sensation, kind of, it makes them feel like they finally are alive, because life isn't depressed or stressful necessarily, but maybe it's just kind of ho-hum, and gambling adds to that. So these same elements, but again, not everybody has the same piece. And I should also point out, one of the things that we're now finding out, which is very exciting in the addiction field, I think, overall for addictions, but also for gambling, is that people are arguing that perhaps we need to stage the illness. What does that mean? Like cancer, that the illness may change over time. And so somebody with a gambling problem who's had a gambling problem, say, for a year, it appears has a different brain biology than somebody who may have the gambling problem, say, for 30 years. In the big broad brush stroke, one sort of sees it as it often goes from an impulsive problem, we'll call it, meaning I find it really rewarding, I'm looking forward to it, I can hardly wait until I get to the casino or whatever my avenue of gambling is. And over time, people say, you know, I just do it. I don't know why I do it anymore. I've done it for years. Every Friday night I go. And it becomes more compulsive, more habitual, less rewarding, but more to stave off negative feelings or increased anxiety. Why do we care? It appears, one, those are different brain centers. We know that psychotherapy, as well as medication, but psychotherapy, when it's done, addresses certain brain abnormalities, if you will. So if we do fancy brain imaging before therapy and after therapy, we can actually see the changes, but the different therapies may affect different parts of the brain. And so understanding the difference between something that's very reward driven versus very habit driven becomes terribly important. And we're trying to understand how better to focus our treatments on those. So for example, motivational interviewing can sometimes really get at some urge quality and dampen it by understanding about the future and how people are seeing the consequences. It's more difficult to think of motivational interviewing as useful necessarily for a more compulsive or habit-driven type of behavior. Maybe, but it seems as if it would work more on the impulsive side as it has for many addictions. So this is where we want to sort of think about what other things can be added, what needs to be changed depending on the person. And as I've already mentioned, some other core qualities, the tolerance and withdrawal. And when I mentioned that women tend to go on to addiction quicker, that's what I meant by the telescoping phenomenon. It's just that women progress much faster, and so the course is telescoped or shortened. So I want to just say a couple things about biology briefly, because I think it sets the stage for what evidence-based treatments, what we do and why we do them, right? So we have multiple brain structures, right, that affect all of our, what we call motivated behaviors. When I want to do anything, I take account of a lot of different feelings. I take account of my internal state. Am I hungry? Am I in discomfort? Am I excited? Am I sort of revved up for whatever reason? I take account of the environment. What can I find? How much risk is there involved? If I want to go there, is it too much effort, etc.? And also my personal experiences, which is, I like to do this in the past. Was it rewarding? Oh, it helped me not be depressed. And so this circuit and integrated circuits of our brain that help us understand, why am I doing something? Why do I stand up right at this moment, right, and go to the kitchen and get something to eat? Well, I'm kind of hungry, I'm a little stressed, I'm a little bored, I'll have a chicken sandwich because that kind of makes me feel better if I remember the right? And so we put all of this together and our brain processes this incredibly fast. This is essentially the integrated circuits that are hijacked by gambling problems. So then we start putting that in terms of other behavior. So our motivated behavior is gambling as opposed to something else. And so it is not, from a brain understanding, different in kind from anything else we do. It's different in degree. And so if you take a picture of somebody's brain with gambling, it's not like there's a big tumor in there that says, oh, that's really odd. It's that certain circuits are overactive and other circuits are underactive. Often overactive, meaning we want something more than somebody who doesn't have a gambling problem, and underactive, meaning that we assess risk very differently or we don't pay attention to risk in the same way. Also, we've learned a little bit about and all of those circuits are connected through chemicals, right? And so we've learned a little bit about that and the role of dopamine as people are very much aware, and Parkinson's. This happened about 20 years ago, and it confirmed what people had speculated about, that when people were taking these medications that ramped up their dopamine, when they were taking them for Parkinson's or restless legs, that some people started having gambling problems. But I will say this, it's not that dopamine agonist, meaning it revs up dopamine, was by itself enough. And so only about 10 of people had a problem. Although if you see somebody who is taking one of these medications, quite frankly, sometimes if they can talk to their doctor and stop the medication, their gambling disorder or gambling addiction is often just cured. Quite frankly, it'll just go away. So one does have to be aware of this, and this is why in the DSM-5 criteria for it, it said you can't make the diagnosis of gambling disorder if somebody's taking one of these medications. But it's also a little bit more complicated than that, isn't it? It's a lot of variables, and part of that is also family history played a role. If I took the medication and my dad was an alcoholic, I was at a higher risk of developing a gambling problem. Be that as it may, I think what we take away from this is it told us a key element of what goes on, and much like other substance addictions, it's about that reward chemical, or chemicals, as it turns out, but somewhat the reward chemical that is often overactive in the case of people with gambling. And I do think what's also interesting about what we learned is there are some lifestyle choices that people can make also that can affect that chemical, meaning high dose caffeine may increase dopamine in some people that are particularly vulnerable to it. We do know that ADHD drugs, which are stimulants, are very pro-dopamine, and they can also worsen a gambling problem in people who genuinely don't have ADHD. If you have ADHD, they can actually help a gambling problem, thereby just making it a bit more complicated. But we've also gone a layer below just the gambling, right? And so between the gambling, I gamble too much, and trying to understand all this stuff in the brain, which is really not possible at this point on any useful level, meaning we can do it in a research university because I can have a lot of people come in and we kind of get a group mean of, say, several hundred people with gambling problems. But on an individual level, does it serve anybody, Bill Smith, getting back to him again, would it serve him to get his brain scanned? Not at this point. In fact, a single individual, it won't tell us very much. So what do we then have? Well, between those things that are going on in the brain, or cause and genetics, and the behavior, I gamble too much, there's a whole host of cognitive factors. And this is how we think through problems, how we think through our stress, how we cope with things. All of these are what we would call cognitive domains, meaning how do I respond to my stress? How do I understand the state of my body, the state of my mind, etc.? And how do I see those things that I need to find relief in? Those are all, as we know, cognitive processes that then can be distorted in people with gambling problems. And again, in depression and in anxiety, which is why historically cognitive therapy of some sort has been quite helpful for many people, because it sort of says, look, you don't have to go to the casino every time you and your spouse have a fight, right? It's not the only way to escape, right? There may be healthier escapes. And so that distortion that happens, we can sort of see if we can actually adjust that and correct that, because it's a little bit more specific to the person than, say, just the behavior, and not as specific though as the actual abnormalities, which unfortunately, as I said, we can't get at. So even cognitive testing on people with gambling problems can be enormously helpful, much like we would do psychological testing, sort of core cognitive aspects, because we see time and time again that there's a list of cognitive deficits in people who have gambling problems. Now, one of the questions is always, if I gamble enough, do I develop these deficits? Or did the deficits occur before I started gambling? And that's why I had a problem with gambling. Most of the evidence would suggest that in most people, the deficits happen first, that these are developmental, and we see them in adolescence, even before people start gambling. As we've been following hundreds of people with gambling problems now for years, we saw these in healthy young adults and adolescents. We were actually able to see that some of these predicted some of the gambling problems. So planning for the future is often a deficit, meaning I just can't think of what a year from now is going to be like. I may not have cognitive flexibility, meaning do I take account of new information and change my behavior? Right? I mean, it's kind of the old story that if you drive home the same way every night, you're probably sort of inflexible. But If that tonight there are big signs saying bridge out, turn around, go another way, you hope that your brain is flexible enough that it says, huh, there's a bridge out, I'm going to turn around and go the other way. And what we see in folks with gambling problems is that they will say, can't pay attention to that. This is the way I do it. I always do it this way. I'm going to continue to do it this way. And this is a bit of an exaggeration, right, with a bridge out. But what it shows is that they don't take account of that new information, that this sort of inflexible approach. And then inhibition. Inhibition you might think about as, say, the potato chip test, right? Can I inhibit a behavior even after it gets started versus, if I have 2 potato chips, I have to have the whole bag, right? And so these, and there are many others, I just highlight 3 that have been fairly well studied. There's also delayed discounting, meaning, if I have to wait for a reward, I discount it and I really need an immediacy of reward, even if that immediate reward is kind of not as logically rewarding as waiting, but it's now, so I want it now. But not every person with a gambling problem has the same distortion. So Bill Smith may have all 3 of these, where Susie Johnson may have 1 of these. And so if this is a key element to why people may gamble or continue to gamble, then it really does sort of behoove us to kind of understand on an individual level where the person's deficits are. And just as a bit of jumping to the punchline here too, you may see, and now there are some interesting data to support it, that in the substance field, what people are trying to do is actually give young people, particularly young people who may be sort of more sort of what we'd call, plastic in terms of their development and their brain, but they've been looking at, say, if you have a problem with inhibition and you are drinking too much. Well, I'm going to then give you a computer-based task, and it's going to increase your ability to say no, because it will improve your inhibition. And you just do that task all day long, right? A couple hours every day, right? It's your physical therapy for your brain over and over again. And they've actually found that if you can target key cognitive dysfunctions or deficits in some folks with substance problems, as opposed to giving them the whole kit and caboodle, right? We do week after week of types of therapy with this and that component. Are those all equal? We might think, well, it's very holistic, but maybe the person doesn't need all of those other components and they need one piece much more intensely. And that's the idea behind doing what is now called cognitive sort of rehabilitation and focusing on the deficits that people have to see if you can improve those and thereby improve their ability to stay abstinent or sober. And we're seeing some really interesting results from these tasks, very positive results, which is very exciting. And this also has led us to this idea that, as I mentioned, this impulsive compulsive idea that people would think, oh, some people were impulsive and then they become compulsive. But the reality is that there's a whole bunch of sort of elements. So some people can be highly compulsive and highly impulsive, fit into one quadrant, whereas somebody else with an identical gambling problem might fit into another. And then to understand what that means cognitively, that profile to really target it may be very helpful. So what does all of this mean? I'm going to show you what historically we've been using and then discuss some of the problems with some of the evidence-based treatments and how maybe thinking about it much more the heterogeneity within it may be more useful, right? So part of the issue that we have, obviously, with gambling is that people really are ambivalent. So one of the things about evidence-based treatments that are researched is that we still have high dropout rates. We have high dropout rates from clinics in a clinical setting, but also in research. And it's often because people will come in and they're very clear that they want to stop their gambling when they come in often. But often what they really mean is they want to stop their losing. But the gambling itself is quite rewarding. And sometimes it's the consequences that bother them the most. I've had people tell me, boy, if I won all the time, I would have no problem with this. Well, that's probably true. I'm not suggesting otherwise, but it's kind of part of the whole picture. You don't get to pick and choose the losing and the reward from it. So, so we do see people come in and out of treatment, which has complicated some of our understanding of evidence-based treatments. Probably the most used treatment around the world is Gamblers Anonymous. And Gamblers Anonymous has been around since the late 50s. It's available in all metro areas, if not even smaller areas now. And it is a tried and true approach. Gamblers Anonymous actually has quite a bit less evidence to support it. It has a lot of testimonial evidence, which is valuable without a doubt. Less evidence to support it in and of itself, and it does have high dropout rates. We're not really still sure necessarily. These are of people who gamble. Very few people go to GA. Very few people stay with GA. It does have less sort of compliance, if you will, than say Alcoholics Anonymous. But also NA does too, has very high dropout rates. So some of these addictions, even I would argue, are not all the same. Just because somebody has a gambling problem doesn't mean that we can say, oh, you're just like an alcoholic person, right? It's not the case. There are very nuanced differences between how drugs and the behaviors work. Gambling may be more revving up, such as, say, a stimulant, and some of our brain imaging data shows that a brain of a gambler looks very much like a brain of somebody who has a cocaine addiction, not so much as somebody with an alcohol addiction. So whether some of the 12-step, whether there are certain people with gambling who will respond better to Gamblers Anonymous, that's one of the questions that is still somewhat unclear. We do know that those who are more likely to stay have realistic expectations, which one would imagine, and those who drop out often want to do a controlled gambling and aren't always upfront about all this to themselves about the severity of their problems. I should say that in terms of controlled gambling, much like controlled substance use, this has still gotten a lot of interest. It's still a bit of an uncharted area. Who can achieve controlled gambling versus those who can't? There's some suspicion that it's a small number of people, but the problem is that we don't have predictors. So Bill Smith says, oh, I want to gamble a little bit. I don't know if Bill Smith can do it. There's clearly some people who can, but we also don't know what differentiates those who are able to do that versus those who can't. It may not have something to do with the severity of their gambling. It may have other psychological or personality variables that may be at play too. This also makes me also want to mention natural recovery in gambling is about maybe a fourth to a third of people with a gambling problem actually achieve what is called natural recovery. And that means that they don't go to GA, they don't go to a religious figure, they don't go to therapy, they don't take meds, they just recover from their gambling completely. And we are just starting to get some information about what these folks are like as well. And they also, it doesn't seem to have anything to do with the severity of their gambling, interestingly enough. It probably has more to do with personality variables, coping skills, resilience, a lot of other domains that are less understood. Self-exclusion programs are a useful adjunct to treatment. Oh, I should also say just about Gamblers Anonymous. What some of the data shows is that the people who do best in Gamblers Anonymous are those who are also engaged in individual psychotherapy. And those who do individual psychotherapy tend to do better in individual psychotherapy if they're also engaged in Gamblers Anonymous. So this idea of pitting one against the other or options against each other may be a bit of a false sort of comparison, meaning it may be actually the better approach to actually see things as complementary, that for some people at least who are doing individual therapy, Gamblers Anonymous may be a very helpful adjunct to their recovery, whereas other people who are in Gamblers Anonymous may find that doing some individual therapy is also helpful for their primary focus on Gamblers Anonymous. Self-exclusion programs have also been used for quite a while, and they differ based on the place and the outlet, usually card rooms or casinos, etc. We do know that people who use self-exclusion programs, who get benefit from them, are again those who are already in individual psychotherapy for their gambling problem. That these are the people who tend to get the most out of a self-exclusion program. And quite frankly, people who exclude, who are not a part of that, are a little bit less understood, meaning that there's less data on those folks. It's important for family members clearly to understand that self-exclusion is not itself a treatment, because it doesn't come with anything other than excluding somebody. Family members often, I think, mistakenly think it's going to keep their loved one from gambling. And as we know, people can go to some other place to gamble. They can gamble online. They can gamble in person or through bookies, etc. So it's not a panacea for all gambling issues, but it is helpful when you assess somebody for treatment about motivation. Sometimes if you say, well, look, there's a, casino, if that's where you go, you could exclude. And if you watch their jaws drop, it may suggest that for all of their, protestations saying, yes, I'm completely committed, whatever you need, whatever we need to do, I'm going to do it, may not truly be, and it may suggest that ambivalence that often people have. Now, here's the thing about the psychosocial treatments. There have been multiple studies now looking at different types of therapy. Most of the therapy has been some variation of cognitive behavior therapy. It helps raise awareness of how people distort their thinking to feed their addiction, so to speak. Oh, I'm really stressed, and the only way I can calm down is to gamble. Really, the only way, right? So that's an irrational cognition, and it works on restructuring that. And then clearly, from the behavioral side, to understand the reinforcers, to come up with things that compete with those reinforcers, to change the environment, etc. The reason I said 1 to 16 sessions, which is very interesting, is that it's not clear when Bill Smith comes in the office how much therapy he needs. Now, we might say that the therapy of choice is some type of cognitive behavior therapy, and that's still a fairly broad umbrella. But we also don't know how much. And some of the studies out of Canada have actually shown brief interventions of even 1 session can be very helpful for people. Providing psychoeducation about gambling addiction, about how they distort their thinking, etc. And what's been interesting, and I've got a slide to show in a bit, is that the brief interventions are, again, not necessarily for the mild, sort of easy clients who are easy to treat. It actually has been effective for some people who have a very severe gambling problem and even have gambled for many years. So again, it must be something beyond just the symptoms of gambling that may suggest who may need 1 session versus, say, 16 or 16 plus sessions. And part of that is still being worked out. But if somebody tends to improve after 1 or 2 sessions, you may want to think about doing some booster sessions, but the person may not actually need substantially more than a couple sessions and actually do well, which is, I think, an interesting thing that's quite unique to gambling, perhaps. We don't see this to any of the same degree in other substance addiction. And so what's unique about gambling, we don't know on that front. But when people even drop out of treatment after a couple sessions, and you think, oh, they're falling apart and they must have relapsed and all of this, it actually may not be the case. We've actually polled, hundreds of folks over the years that we've seen who dropped out, and maybe we'll call them back in 6 months or 12 months and say, hey, why did you drop out? What's going on? And it's amazing, a substantial number of these folks saying, I'm all good. I mean, everything's been going great. I haven't gambled, got my life back. I'm enjoying my life. Those 2 or 3 sessions with you were great. And at first I would think, great, are you serious? I mean, I have so much more to dazzle you with, and yet they were doing well after a few sessions, explaining what the addiction was, what the goals of treatment were, and sort of the basic parameters of it. And sometimes that's all people needed. And so it may be, much like we see with natural recovery in folks with gambling problems, what people do in natural recovery is simply use their resources that they have from a psychological, spiritual, willpower kind of way, whatever one wants to use it to say it, and they figure out how to get healthier. Now, maybe what is happening in some of these brief interventions is some of those people may have done it on their own, or maybe just like a kind of a personal trainer, all they needed was for you to tell them a few exercises and then they're good to go. And so I just suggest this because sometimes we all have an assumption that more is better, right? That, oh, you have a huge problem, you're going to be in therapy for 35 years. And maybe they will be. Some people, of course, are. And some people may need that and not want it. But there may be also a good chunk of people who don't need it, don't want it, and it's more about the clinician needing to be somewhat flexible in terms of modifying the treatment plan. As I said, the cognitive behavior therapy, if both elements are used, and most people would do both cognitive and behavioral of some sort, involves psychoeducation, the irrational cognitions, and then understanding context, emotional context, triggers, environmental triggers, etc. And this is a standard kind of ABC log that people often fill out as part of cognitive behavior therapy. Most of the treatment data has shown that it is homework exercises and writing out one's thoughts, the triggers, etc. Sometimes I think in therapy, we all probably do it to some extent. People do a type of cognitive behavior therapy without homework. But what we know is from the research data is that, one, keeping logs and writing things out slows our brain. It makes us more thoughtful about what's going on as opposed to, yeah, I got it, right? That takes 2 seconds. If I have to actually write out these steps, I have to actually think about it, and it slows things down. And particularly if I'm fairly impulsive, that may be a good thing to slow me down. And it just really makes me much more aware of my behavior. One cannot change a behavior unless you have a certain level of awareness. The greater awareness, one would argue, then you have a much greater chance of modifying the behavior because you understand all of the triggering emotional contextual variables. And so it's very important, I believe, to have people do their homework, because it allows them to become their own therapist ultimately. Now, the other thing about cognitive behavior therapy is it's been well studied in group formats, actually. So it doesn't have to be on an individual level, although most of the groups, and when I've done groups, I would run a group and then do a little bit of individual. So because, again, some of those individual cognitive distortions are unique. Some of the behaviors are also different contexts that can be helpful. And all of this can be useful for folks from a group context as well. I've already mentioned the brief interventions. It can be a single session. It can be a workbook, a reading list. Motivational interviewing can be done as a brief intervention, right? 1 or 2 sessions of it, perhaps. Often it's used as part of a cognitive behavioral package, so to speak, that people would keep a cognitive behavior diary and then do some emotional interviewing on the front end or the back end. So it can all be mixed and matched. And motivational interviewing is a type of CBT from the big broad picture of it. And the workbooks, when I'm talking about workbooks, are very cognitive behavioral oriented as well. And this has been largely done by the Canadian researchers as a way to also get the most people into treatment for people who may want who are impulsive and want quicker answers to things. It allows them to sort of move at their own pace. If they want to move through workbooks faster, they can. And it's all been done with quite good success. So just something to keep in mind. A different type of cognitive behavior therapy that's shown benefit for the last 40 plus years now, started by the Australians, many years ago, is something called imaginal exposures. We tend to think of exposure exercises as something done for anxiety and phobias. And this is using a cognitive behavioral framework for exposures, meaning you actually have them do it as an imaginative exercise, not actually in a casino or at a gambling establishment, but they would create scripts that then trigger their desires, but then talk them through the problems and options to deal with it. So I just highlight here a little bit of how that might look, and you would have the person detail their narrative. And this is, it gets very individualized. It's not as if Bill Smith will write the same narrative that Susie Johnson will, but he will write something such as this, talking about his desire to gamble, the other triggers. Work has been stressful. I want to escape. I want to have some fun. I'm bringing money, etc. And the expectation of reward. And you would go on, and I don't have it here, but you would go on and then have him say, okay, now I'm out of money. I'm nervous about going home. We're going to have a fight about finances with my partner. And then a third piece to help him sort of rescue it is, okay, instead of having gone to the casino, I could have done blank instead with this stress and this need to escape. I could have called my brother and we could have gone to a movie. I mean, you know, assuming non-pandemic world, right? And so you'd modify it differently for current state of affairs. But, and then have them talk about an outcome that is a positive response to the stress, etc. And this can take, it may take 45 minutes to craft for Bill Smith, but what it does is it allows him then to be triggered, and he would listen to himself record this. He would listen multiple times a day. Probably takes 5 minutes tops to hear it. And it would take him through it and then tell him about the negative consequences, but end on a positive note of control and healthier life, right? And so he would be triggered over and over again. So the idea being that then when a real trigger happens and it is a stressful day at work, he's not taken by surprise, right? He's sort of like, oh yes, I've been playing this through in my mind every day, multiple times with my tape. And therefore, I don't need to do it. I know how this ends. I call my brother and I go to a movie. And so this has been helpful. We started looking at this through with funding from the National Institute of Mental Health many years ago when we compared it to Gamblers Anonymous and looked at percentage of people that improved, meaning being abstinent from gambling. It was much more successful than just going to Gamblers Anonymous on its own. Again, often probably because of the high dropout rates. But even 6 months, and then we've looked even now several years later, and the data is still really quite high, in the high 60s still. The Australians found that the folks that they treated with this type of cognitive behavior therapy were abstinent from gambling 10, 12 years after they had done their original studies. So there's something about, again, providing the locus of control back to the person with the gambling problem. And so I think it can be also a different type of cognitive behavior therapy that's quite beneficial. And this is an example of motivational interviewing, a homework exercise. And this I've written out as any type of behavioral addiction or impulsive behavior, but it can be specifically, obviously, written for gambling. This is one of the few treatment approaches, motivational interviewing, that has been helpful uniformly across all addictions to some degree. And again, who responds best to it is still a bit of a question, but you can sort of see how it also works cognitively. What are the positive aspects of my gambling? What are the negative aspects? So I have to learn how I may be distorting my understanding of gambling, that it's all bad or all good, right? What are the negative consequences of continuing it? And then what are the advantages? And that also helps me plan for the future. So I mentioned a cognitive distortion is often a planning deficit, and this helps with that. So it can be useful, and there's probably a group, maybe people with some cognitive deficits, that it would work better for than others. And then finally, the other type is contingency management, which Nancy Petrie really brought from the addiction world to the gambling world several years ago, and she was a strong proponent of it and did many studies showing it's beneficial. And basically, it's coming up with incentives or reward to change an addictive behavior. Now, again, you don't want them to be prize drawings for gambling, as one might do for negative urine screens, but different types of privileges that one gets. The idea being is that whatever the reward is from the gambling, that it can be replaced by a healthier rewarding option. This has been interesting, and I remember when she started doing it, people started criticizing the concept of it in addiction, saying, well, why should we be rewarding people for things that they shouldn't be doing to begin with? And I think that's a little bit short-sighted, meaning that if we go back to how the brain sees gambling, for many people, when it's seen particularly as a strong reward, however that means, either getting something or relieving a negative something, right? Then the idea is you can either hope that the brain just changes, right? Or you replace it by something that's not as rewarding, such, I mean, but those are all much more challenging depending on where in the addiction the person is, because the brain is looking for a certain level of reward. So then how can one try to not maybe match the excitement of gambling, but something that's close that will then but be healthy? And so the brain can then say, oh, that is rewarding. So the best example of this could be, I mean, in contingency management, you do it, say, every week that the person doesn't gamble, they get a different reward and the rewards increase. This is basically, I think, very familiar to all of us in part, right? Because this is why people work. And if you work hard at a job, you get incentives as bonuses, etc. So it makes sense from the brain, but you could also imagine exercise being used, etc., as other healthy options. And then I only have a couple minutes because it's a big field and I'm trying to move along, but I want to say something about medication piece in this, some people think of medication as a quick fix. We don't have such a thing for gambling, but keep in mind we do have medications for opiates. We have medications for nicotine as well as alcoholism. And what they all have, the goal has been, is to maybe take enough of the craving away, maybe help people with inhibition, to make it a little easier to take advantage of psychotherapy. So I think it's just very important not to think of it as a cure-all, but as an adjunctive option for people. What we probably know is that one of the best areas, borrowing from the substance, are opiate antagonists. This would be naltrexone in the oral form. There is a Vivitrol shot used for alcohol. We haven't tended to look at that for gambling because, again, my view about it is that people should be on board with taking a medication and not necessarily sort of feel like it's been done to them, but everybody could be different. It could be as effective as naltrexone. This is some early data from 30 years ago, just showing that the medication can help decrease the urges, not to zero, but it decreases the urges, and that may be enough to help people be able to better take account and be informed about 12-step programs as well as psychotherapy. We've also looked at an all-natural substance in gambling called N-acetylcysteine. This is a drug that's been used for the treatment of cocaine addiction and marijuana. It's available over the counter. Its effects on a chemical glutamate, which kind of controls dopamine. And it was shown to be helpful in gambling. This is just a scale of gambling urges and behavior, and it was able to cut these things about in half. And it's available over the counter. It's an antioxidant. It's good for people's liver and their kidneys. And then finally, we've looked at more experimental drugs, meaning this memantine is a Alzheimer's drug that helps with improved decision-making capabilities. And we've looked at that in gambling, and it actually, on an objective cognitive task, was able to improve cognitive flexibility in people with gambling problems. And as it did so, they quit gambling. And then even something like a COMT inhibitor, which works in the front part of the brain, also to improve our executive functioning. It helps us make better decisions, has also been looked at quite successfully for gambling, and even based on genetics, it may be beneficial. I had some cases here, but in the space of time, I just want to say integrated treatment, these are all part of that because there's a whole host of other issues that come along with gambling, as you see here. There are co-occurring problems and high rates of suicide, all needing to be addressed. And so the treatment needs to account for all of that, but I wanted to present the evidence-based treatment specifically for the gambling problem itself. So Excellent.
Oh, Dr. Grant, thank you very much. Great presentation. I've got a couple questions. There have been a few others that have come through, but I'm going to go ahead and get a couple of the poll questions out now for everyone that have been chatting me. They're so excited for these poll questions, Dr. Grant. So, okay, so here's your first one, guys. As far as what Dr. Grant has covered today, all of the following psychotherapies have been found to be beneficial for gambling disorder, except for which one of these? Is it A, cognitive behavioral therapy? Is it B, imaging exposure? Is it C, motivational interviewing? Or is it D, rebirthing therapy? Now, I'll give you guys a couple of seconds here to answer, and then I'll hand it back to you, Dr. Grant. Which one of these? All belong except for what with the psychotherapies? Is it A, cognitive behavioral therapy, B, imaging exposure, C, motivational interviewing, or D, rebirthing therapy? I know we can get to 80% here, guys.
Yeah.
Right? Yeah.
I think you're good. I think.
Yeah. Okay.
But if you watch old Law and Order episodes during the pandemic, you'll see rebirthing therapy on one of those, which is really, where I got that question, that idea from. So.
Yeah. Okay. So the answer was D, rebirthing therapy. Very good. Okay. And we'll just so we can get to a couple of questions. Let's do one more. And here are your results. Okay, we got that. So let's do our second poll question. Let's see here. Stop share results. Okay. So which of the following medications, here it goes, I'm sorry guys. Which of the following medications is FDA approved for gambling disorder? Is it A, naltrexone? Is it B, boy, Dr. Grant, help me with the pronunciation of this.
N-acetylcysteine.
Thank you. Is it C, both A and B? Or is it D, neither A nor B? So which of the following medications is FDA approved for gambling disorder? Is it A, naltrexone? B, what Dr. Grant just said? C, both A and B? Or D, neither A nor B? Okay, I think we can get to 75%. Stretch goal 80%.
Yeah, I think it's good. The reality is that there is nothing FDA approved for gambling. No company has tried to get a drug approved for gambling. There isn't one. It's interesting that given the fact that we have 3 approved for alcohol, a couple approved for nicotine, and a couple approved for opiates, we have nothing yet for gambling. And that's just, I think, a bit of a testimonial to gambling's a bit farther behind.
Okay. All right. Wonderful. And I've got a quick question before I ask you the next question, because I know what the next poll question is, and it asks about comorbidity, right? And, a lot of time in our training, actually, we talk about the NESART study and the comorbid condition of gambling disorder or alcohol use disorder. Out of that study was the highest, had the highest comorbid rate with gambling disorder. But I know that last poll question, you talk about nicotine being the highest. Can you speak to that?
Yes. So so nicotine will be the highest current comorbidity. If you look at lifetime comorbidities, alcohol it runs neck to neck. But many people, once they actually move into gambling, interestingly enough, often give up drinking because of gambling. Wow. And so, but they don't tend to give up nicotine. Nicotine often makes people feel like they can pay better attention, that it'll help keep them awake if they want to be at a casino for many hours. Keep in mind, there's nothing good about nicotine, but people feel that there might be some reinforcing effects like that. And that's why but whereas many people who've had alcohol problems quit drinking when gambling gets quite severe, because they'll tell you it makes them stupid, right? I mean, if they're drinking all the time, they can't be on top of their gambling.
Right. So. Makes sense. Okay. Yeah, I was interested. Yeah. So thank you for that. So Real quickly here, we have one of the questions that came through about 15 minutes in. Dorothy asked about sex and gambling addiction seem to have a similar impact on the brain. Is that true?
Yeah, it probably is actually. And, this is where Las Vegas figured it out, right, many years ago, that you want all of those rewarding things in the same place. You want high fat and high sugar foods, you want sex availability, you want gambling, you want drugs and alcohol, right? I mean, it's all the rewarding things. The problem with the sexual piece is it's actually been a little bit more complicated to study, because there's a lot of reasons where people have sort of hypersexual behaviors that might be unique from other addictions, right? There's self-esteem issues that often body image issues, intimacy issues, etc. But when we do analyze the brains of people with sexual kind of compulsive or addictive behaviors, we see it very similar to what we see with gambling. This overactive reward that's 10 times greater than a typical person might view sex. And we do see a fair amount of comorbidity. But I will say this, that sometimes you have to treat somebody with a gambling problem for a long time before they want to talk about their sexual behavior. I mean, there's still a lot of shame, even more shame around sex than around gambling for many people, because it may involve infidelity. It runs a host, and because sexual behavior can get, they don't want the personal questions that are followed up if they say that, right? They may feel like they are offending you if they talk about pornography, or if they talk about infidelity, or if they talk about something more atypical in terms of sex. So people often do feel like they really need to know you well and trust you, which makes sense, before they're going to discuss really intimate issues.
Right. Yeah. Okay. Well, thank you for that. And we're a minute past the hour. If you guys need to leave us, we want to thank you. And please go to weknowthefeeling.org to register for their October 12th considerations for mental health professionals in a digital age. So that's our next webinar. And stay tuned for, the upcoming 4-day core training disorder that will be up on the website. Dr. Grant, do you have just maybe a couple more minutes, if you don't mind? I've got a quick question. I know you got a tight schedule, probably.
Sure, no, but if you got a question, I'll do it.
Okay, so we had a chat right away from Kirk, and he asked, when you're working with patients, what % do you end up working with the entire family as far as counselor, as far as, working with a problem gambler? What % do you actually end up working with the family on?
It's I would say probably 20 to 30%. And it may not be the entire, it may be bits and pieces of family, depending on who they define as their family, also who they define as their family moving forward, and even to some degree, what members of the family even want to have a part of the person's life anymore. Right. So sometimes, as we all know, that by the time somebody comes in with a gambling problem, something is falling apart.
Yeah.
And if the family is falling apart, sometimes you can't get them in. They're done. Yeah. They're out the door, so to speak. But then it might be a best friend who we now sort of consider, for lack of a better term, family, right? And kind of have a support network, if that's sort of a loose concept of family as well. So I think, and it also is about timing. Some people want to have some control over their behavior before bringing the family in. I get it. We all want to win in the win column. And so a little bit has to do with how dependent they are on money, all of those types of things, when I might nudge the family to come in. And so I think it just has to be very individualized. Okay,
wonderful. Well, thank you for that. And the rest of the texts and questions I saw were just thank yous and praise for your great presentation. And I always appreciate, being a social worker, your talks on the neurobiology piece behind problem gambling. Today, the underactive and overactive responses of the brain. The underactive I found really intriguing, and those executive function deficits that you spoke about at the very first, and working through them, like the analogy you use with physical therapy. I really like that. And how the disorder progresses over time. I see that in all addictions, and how it changes, and how our treatment approaches should change with that, right?
They should. Yeah. And that's where we need our own flexibility, don't we?
Yeah. So, hey, I hope we get to work again. I think we are, but
Probably.
yes, I really enjoyed it today, and you have a great rest of your day. And everybody else, you too, thank you for joining us today. We hope to hear from you on October the 12th. Okay.
Appreciate it.
See you,
Thank
Dr. Grant. All right.
you. Bye.
Have a good day.